Welcome back. Today's lecture is going to be on flap technique for pocket therapy. Now, many of you would have heard about flap surgery. Now, whenever there is periodontitis and associated periodontal pocket, a lot of pathological changes take place, which result in loss of hard as well as soft tissue. Usually, there will be a deep periodontal pocket, which in the initial stages we try to address by means of scaling and root planing. And with scaling and root planing, probably a part of the disease is being controlled. Suppose you find a case, and that case has got about 6 millimeter of pocket. So in the initial stage, what you do is you do a procedure called as scaling and root planing. So after scaling and root planing, you probably reevaluate the patient, recall the patient, and recheck all the clinical parameters, and then later on you find that the pocket from 6 millimeters come down to around 3 millimeters. You don't have to do any sort of advanced surgical techniques. Now the disease is under control, but there are certain situations in which probably the pocket wouldn't have come down bit, and the pocket is remaining as probably 5 or more millimeters. In such cases, you probably have to do a surgical treatment, which is called as a flap surgery. So in this topic, or in this lecture, what we are going to discuss is about the different types of flap surgery by which you can eliminate the periodontal pockets. Now, what does flap accomplish? Flap means you are reflecting a part of the gingiva and or mucosa. And when you are reflecting a part of the gingiva and mucosa, this is what we accomplish. One is you have greater access to the root surface. Root surface, you can clearly visualize the root surface. Now, as a result of different type of incision that you put during a flap surgery, you can eliminate or reduce the pockets, the pocket line. And also, when you reflect the flap, you are exposing the underlying bone as well as teeth. And this helps in incorporating a lot of regenerative techniques in the form of probably placing a membrane, that is guided tissue membrane, placing different types of bone grafts, use of biological modifiers. All these can be incorporated. So all these can be accomplished when you reflect and open up a flap. Now, there are certain things basic for a flap. We have discussed all these in the previous class. That's about incision. Now, these are the 3 incisions that are basic for any type of flap surgery. First is the internal bevel incision, starting from just the gingival margin to the almost the crest of the alveolar bone. Then you put a clavicular incision all around the tooth through the sulcus, otherwise known as sulcular incision. And only in the interdental area, after you have reflected the part of the flap, you can use an interdental incision using Auburn's interdental knives. Now, when you talk of different type of flap surgery for pocket elimination, you can classify into these 2 groups. Okay, the first group is exclusively for pocket elimination. That is, one is you have the modified Whitman type of flap surgery. It's the most common type of flap surgery that we do. There is something called as undisplaced flap and an anti-displaced flap. And whenever you are trying to incorporate regenerative techniques, which I mentioned earlier, you probably go for these 2 type of flap, which is known as the papular preservation flap or a conventional flap. So we are going to discuss the steps in doing all these or any of these flap surgery. And basically, any of these techniques can be asked as a short note for you in the exam. That is something that you should always know. So first we'll discuss about modified Whitman flap. As I told you before, this is the most common type of flap that is usually being done by a periodontist. It was first reported by the name of unrepositioned mucoperiosteal flap by a gentleman called as Morris in 1965. But no one took notice of that. And Later on, the same procedure was reported by means of Bamford and Missile. They termed that as a modified Whitman flap, and that's the same procedure that we do nowadays. Now, in this modified Whitman flap, or why this flap is mostly used by periodontics, is it does not remove the entire pocket wall. What it does is, by means of the different incisions that we put, we try to remove only the pocket lining. So you all know that whenever there is a gingival sulcus or periodontal pocket, the soft tissue lining the pocket, in the lining is being inflamed and it contains a lot of diseased tissue. So you, rather than removing the entire lateral wall of the periodontal pocket, you just remove this lining, and that is how you try to achieve pocket protection. So in the first step, what you do is internal bevel incision. We discussed about internal bevel incision in the last class. So about 0.5 millimeters. So suppose this is the gingival margin. This is a black and white photograph. I don't know whether you can appreciate it well. So this is the gingival. About 0.5 millimeter from that incision, and it is directed towards the crest of the mouth. So here, like this, you put an incision just about 0.5 millimeter to the gingival margin directed to the crest of the mouth. By putting this incision, what you're doing is this is the inner lining of the pocket. This is the outermost wall of the pocket. So you are just removing this inner lining, which is diseased. So that is the basic idea of giving an internal bevel incision. Then second is, you just into that incision, you push the Bujos-Vijayata, slightly reflect the gingiva. And what we need, the reflection that we need is, we just want to see 1 or maximum 2 millimeters of the alveolar bone. That is it. Don't excess much, elevate much beyond 2 millimeters. But whenever you are exposing too much of bone, there is going to be bone resorption there by means of different phenomena, known as the plant or not. Okay. Then the gingiva is reflected, as you can see. Okay. So you can see this band of tissue. The same incision you have to put in the palatal aspect also. Okay. And you have to do it in the reflect this the palatal aspect also. So you get a V-shaped tissue all around the tooth. And then you put your second incision, which is known as the sulcular incision or the clavicular incision. So this is your first incision, and then you have reflected this part of the gingiva. And now through this sulcus, you put an incision. So this is your sulcular incision. This incision can be put using EP plate number 11, number 12, or number 15. So these are the common plates that we use. Then what we do is that we put a third incision. Now this third incision is, you can see that instrument. This instrument is known as the Auburn's periodontal knife. Auburn's periodontal knife is this spear-shaped instrument. So this will go into the interdental areas. Now these interdental areas we have not put an incision. So in order to lift this tissue using a curette, or the inner lining using a curette, it will be very difficult if you don't release these areas. So by these Auburn's interdental knife, you are going to insert into the interdental area, buccal aspect as well as from the palatal aspect, and then you draw around the tissues. You release now with the use of the curette, you can just take it out. After that, what you can see is, you can clearly visualize the root surface. You can, with the curette, you can, whatever granulation tissue, whatever is tissue over here, just remove it completely. When the granulation tissue is removed, bleeding there completely stops. And you can clearly visualize the root surface over there. So what you can do is, you take a scaler, completely remove all the deposits. Take your curette it properly so that you plane it properly so that it's smooth and clean. After that, what you do is irrigate this area, and then you close the flap from both sides. So that is known as, these are the steps of modified Whitman flap surgery. So the basic advantage of doing a modified Whitman flap surgery is, you are removing the inner lining of the pocket, the outermost lining, the outermost gingiva is completely uninvolved, and that is completely different. So there will be minimal precision post-operatively when you do this type of flap surgery. At the same time, you have to remove the pocket lining. Good. Then we'll go to the next flap, which is known as the undisplaced flap. Now here, what is the entire pocket lining? Okay, entire pocket lining is removed by means of an internal bevel incision. Now you can't. Now this was historically done. We never. Nowadays we don't use this type of flap because by doing this, you have about 10 millimeter of pocket, and then if you're trying to remove that whole 10 millimeter of gingiva, just recite the gingiva and complete the no attached gingiva remaining. The complete recession will be and it is properly anesthetic. So you have to select. Case selection is very important in this case. So here we'll just go to the. This is an internal bevel incision. Here, so you can see that. Suppose if you have a pocket like this, you can eliminate the pocket by putting an incision here, and reflecting this whole tissue and cleaning up this area. By means of that is what we do in an internal bevel incision. Now, what we do in undisplaced flap over here is now corresponding to this base of the pocket, you put an bleeding point, you mark a bleeding point over here. But then you can take a probe, take a measurement here also. Take this and this. So this point will correspond with your base of the pocket. And from that area, you put an internal bevel incision into the bone. Then you put a clavicular incision here. And this whole gingiva here is removed. And this part of the gingiva you adapt at this level to this level. You will come and adapt to almost this level or to this level. So here you are removing only this lining, the whole gingiva gets adapted here in modified Whitman flap surgery. While in an undisplaced flap, you are removing the whole of the pocket, you are removing. And it will come and adapt to the almost to the where the base of the pocket or the bone is there. And you can see this much more part of the roof is going to get exposed. That is why we don't do undisplaced flap nowadays for pocket elimination. So steps are pocket is measured, a bleeding point is made corresponding to the bottom of the pocket on the outer gingiva. So pocket is measured, bleeding point is made here on the outermost aspect of the gingiva. Internal bevel incision is made, clavicular incision made. The flap is reflected from the internal bevel incision. The triangular wedge of tissue is removed. So from here, internal bevel incision is made, clavicular incision is made, and this whole band of tissue is going to be removed. Then scaling and rotating, all the steps which we mentioned before, scaling and rotating has to be done. Flat margin should rest at the root bone junction. You can put a stick at the water. You can put a continuous suture, interactive suture, sling, or whatever suture deemed necessary at that point of time. So that is. So we've discussed two types of flap surgery. One is the modified treatment type of flap surgery, and now we have discussed about the undisplaced flap surgery. Now, whenever you are doing in the upper aspect, especially in the palate, there is something. This is something that you should know. In the palate, what happens is, the whole of the palatal mucosa is keratinized and it is fully attached to the bone. You don't have to use alveolar mucosa. So what you do, you don't reflect it one way. You can't just, because it's so firm, you can't coronally advance it or apply it in order to stamp it. Cannot be done using it, but in a palatal flap. And because you can't modify much there, you have to plan very well in a palatal area. Every aspect of the incision should be clear in the first incision, so it's very difficult to modify later. And always, because the palatal flaps are very thick, you try to, whenever you're doing an internal bevel incision, you have to anchor it in such a way that the final flap thickness will be very thick. So these are things that you should keep in mind. It won't be asked during your theory question, but these are things that you should keep in mind when doing a flap or reflecting a flap in the patient. palatal aspect. Right. The third type of flap is known as a apically displaced flap. As the name suggests, what does it? It the whole of the gingiva you are apically displacing. Suppose you have a 5 mm pocket, so you reflect the flap in such a way that you displace it at the junction between the bone and the tooth. Okay, so you are completely eliminating the pocket by means of an apically displaced flap. Now, one thing is there are two aspects of this because you are not resecting any gingiva here, you are preserving the whole of the gingiva. So whatever width of attached gingiva you are there, that can be preserved. And the same thing can get proper. That is the basic idea. And depending upon in which all conditions you do an apically displaced flap. Suppose you do for pocket elimination. Sometimes you can do for increasing the width of attached gingiva. Sometimes what you can do is you can do this procedure for crown lengthening procedure. So depending upon the need, you may either reflect a full thickness flap or a partial thickness flap. But when you are reflecting a partial thickness flap, the thing is, you are reflecting that partial thickness flap. I told you before, it contains only a part of the gingiva. It contains only a part of the epithelium and the connective tissue. So this is probably very difficult to do this type of flap. So, and it is usually done using a periosteal elevator. Now it's stuck. Just have to bear with this. I don't know. Sometimes this video is getting stuck. But to really get it done. Just bear with me for a few seconds. Yes, we are back on track. Sorry for the disturbance in between. We are back on track. Okay, this is our slide. We're discussing about the apically displaced flap. So the split thickness flap needs more precision and time. So that is what I was discussing earlier. Now, steps for apically displaced flap is almost similar as an internal bevel flap. Only thing is, I mean, for a modified Whitman flap, but the only thing here is, you have to give vertical incisions on either side so that you can apically displace. You can release and apically displace the flap. So put an internal bevel incision. Following that, you put clavicular incisions. Interdental incisions are made, and then the whole triangular wedge of tissue is being, the pocket lining is being removed. And then on either side, suppose you are localized, you take 1 or 2 teeth on either side and put vertical incisions. When you do vertical incisions, make sure that you extend the incision beyond the mucogingival junction so that you can adequately reflect the flap and displace the flap. That is amazing, right? And then once you have reflected, do every step what we do with all the flap surgery. That is proper debridement, removal of complete granulation tissue, scaling, and then smooth planing, irrigation of the area. And what you can do is then apically displace the flap. Where do you displace the flap? Displace the flap to a junction between the tooth and the bone. And there you put sutures. Now, if it is a full thickness flap, you can put a continuous individually anchored suture. That is a suture that you should put. But in case of a split thickness flap, but you can just, you have underlying periosteum beneath that. So you just have to give a periosteum suture, anchor suture into the periosteum. Now this is, suppose this is where we do a surgery between this canine and canine. So this was where the gingiva was originally, and this is where the bottom of the pocket is. So what they've done is, this is where the vertical incisions are. So you put all the horizontal incisions over here, put the vertical incisions here, reflect it beyond the mucogingival junction, where the bone and the bone meets. At that point, again, you can anchor this with the anchor. Now, this is a case which was referred for crown lengthening actually. So you can see that those crown had fractured trauma, and this is after reflecting a full thickness flap. You can see that on either side we have two vertical incisions are reflected. And then we did a osteotomy here, keeping in mind the final margin of the respiration. At the same time, biological touch we perform. I mean, that needs to be maintained. Then sutures were placed, and you can see that sutures were placed more apically to the where the bone was present. That is where we put the sutures. Finally, much amount of time we got, and over that, post respiration was made. Respiration was given. This is different before and after. Here, what we have done is what was gingiva that was present there, that was apically shifted. Then we did osteotomy, and then at that level we placed gingiva. So we have not lost any attached gingiva. Whatever gingiva that was present has been apically shifted. Then you have reconstructive technique. So whenever you are incorporating any type of bone graft, any type of membranes, any type of biological modifiers, PRF, anything you can do any of these techniques. One is called the papilla preservation technique, and second is the conventional technique with sulcular incision. Conventional technique is a very simple technique in which you put sulcular incision, and you put only sulcular incision all the tooth, and the what do you call the interdental gingiva is just split into two beneath the contact point, so that you can reflect the buccal and the lingual flap. No much of other flaps there. So that is a conventional technique. Only thing is, the whole of the gingiva is there, so that whenever you are putting any graft or any other substance, you can completely cover the graft. That is the basic idea. So you are preserving the whole of the gingiva here. When a papilla preservation technique, as we discussed earlier, now this technique is usually done whenever there is spacing between the two, and especially during in the anterior region when there is spacing, and also whenever you're doing what you call this surgical technique. Now, what we do is, I'll just show you. Now, this is when there is this is a cross section of the tooth. Okay. Now, this is gingiva, this is the buccal gingiva, this is the palatal gingiva. Okay, on the side. So, what we do in normal conventional technique is to put sulcular incision all around the tooth. Okay. To put sulcular incisions all around the tooth. Then what we do is we just split this papilla. So, and when you reflect, this whole half comes to the buccal aspect, and this whole half goes to the palatal aspect. But here in papilla preservation flap, what we do is, you put circular incisions all around the tooth, clavicular incisions all around the tooth. Now, this you are doing when there is spacing. Then there is diastema or spacing between them. So what we do here, you can see that, you can put a semilunar incision like this, either in the buccal aspect or a semilunar incision like this in the palatal aspect. Now, if you are putting a semilunar incision here in the buccal aspect and then reflecting, this part of the flap goes into the palatal aspect. So this gets reflected in the palatal aspect. And suppose if you are doing this, putting this incision in the palatal aspect, this part of the tissue with papilla gets reflected in the buccal aspect. So that is what you should know, where you should put the incision, so that where you want to reflect the gingiva, whether you want to reflect the whole papilla into the buccal or into the palatal aspect. And then you can do all the steps that we discussed earlier, but scaling, opening, irrigation, examination, everything. Place whatever bone graft here, adapt this tissue. So that is what all is being discussed here. The steps. Okay, so the idea is, it offers better post-operative post-surgical aesthetics and more protection to the internal bone when regenerative techniques operate. So that is the basic idea. So to get better aesthetics and can operate off your regenerative material. That is the reason why we are doing papilla preservation plan. And these are the different steps for papilla preservation plan, which I've already discussed. And this is the diagrammatic representation. Now This is a case you can see. Not much of a spacing, but it's not an ideal case. But yeah, here we did. So here and semilunar incision was put on the parallel. And you can see here this whole, the whole tabula. And then the treated here. So this is called as a papilla research lab. This is usually done when there is spacing between the two, especially to the anterior area, one for aesthetics and for coverage of the fingerprint. So that by that we have come to the end of this lecture. That's topic known as a flap surgical techniques, in which we discuss about the different types of flap. We discussed initially on modified Whitman flap. Then we discussed about undisplaced flap. Then the reconstructive technique of these techniques where we use the papilla surgery flap or the conventional flap. So make sure as an undergraduate student you understand the different steps that are involved in each of these, and any of these techniques can be used as a short output. Thank you for listening.